integrated behavioral health into every encounter with patients with diabetes. It is a crucially important part of their care. If we don't do that, we've not actually provided care for the whole person. We're treating a disease. That is what we're trying to get away from. Lastly, I want to talk about the multiple chronic disease management model. Doctors don't like to hear me say this. There's probably some doctors out there that will throw things at me later. A lot of times there is a best way to treat things. Okay? We can agree upon, for many diseases, the way in which we should treat that disease. There is evidence out there that supports the way we do it. And yet when we look at practice as how we manage diseases, there's lots of variability in the disease. There's lots of variability in the way that we manage it. And that leads to variable outcomes. And that leads to higher costs, worse outcomes for those patients. What we want to do is create the standard. We want to look at what is best practice in all of these areas and how do we adopt that community-wide. And so towards that end, we have brought in clinicians and other stakeholders from all of the safety net providers where we sit in big rooms, and they've been incredibly willing to do this work. And we're going to decide what the standard of care is, and we're going to put that in play across the entire safety net. We're going to decrease that variability. We're going to bring the cost of the care down. We're going to improve the quality of it. And patients are going to be happier with that because they're going to get a more uniform experience. We believe in the CCC there should be no wrong door. It doesn't matter where you get the care. The care you should receive should be of the highest quality regardless. All right. This just represents a new model of healthcare. So this is a great diagram I'm not going to read to you, but I want to point out to you the salient elements of this. Basically, this new model of healthcare is around three main partners: Seton Healthcare Family, Central Health, and the University of Texas at Austin. Now, each one of these organizations on their own are doing big things to improve healthcare for the community, but the real exciting stuff comes in the synergies between them. So if you think about the synergy between Seton and Central Health, what they have jointly created is the Community Care Collaborative. Between the two of them, they have partnered to create a delivery system that will really augment the way we provide care. Between the University of Texas at Austin and Seton, we're going to look at Seton being intimately involved in the provision of academic medical education in this community through the Dell Medical School, as well as nursing education, social work education, every other ancillary. And then lastly, between the University of Texas at Austin and Central Health, there is an agreement between the agencies or the university and Central Health for Central Health to help support the activities of the medical school through provision of medical services. All of this together is going to result in better person-centered, higher quality care, which is really more down the road. So we're going to keep moving down here. All right, what does transformation look like? I'm going to hit some highlights on this board. One of the problems we have in the current delivery system is we tend to focus on diseases. I'm taking care of this illness. I'm taking care of this sickness. It needs to be, we need to move from treating the disease to treating the whole person. We need to move away from an illness model into a wellness model. When you talk about illness, it means that as soon as I make you well, I don't have anything to do with you anymore. You don't need the healthcare delivery system anymore, and yet we know that is not true. Because we know that if we could reach out to people in the well state and help them stay well, we could provide better care overall. We could decrease the cost for that. People would be happier. We would alleviate suffering. This is where we need to move. We need to move from crisis care to preventative care. Why do we spend so much of our healthcare dollar in emergency rooms? Because a lot of that ED volume is avoidable if we could have intervened earlier in their illnesses. And so we need to begin to get upstream of the need to use acute care services. We need to move from fragmented care to seamless care. When you go, not you, hopefully none of you tonight, if you end up in an emergency room at 2 in the morning on Saturday, for whatever reason, we think that on Monday morning when your primary care doctor walks in the door, they should get an electronic message that says, your patient was in the emergency room at 2 in the morning on Saturday, and this is why they were there, and this is what was done for them, and this is when they're going to see you again. And if you have any questions at that point, Office staff can just call them and say, hey, how are you doing? Do we need to see you earlier? Now, I would challenge you, probably everybody in here has an insurance card. But what I can tell you is nobody's getting that care in Travis County today. That isn't happening, but we're going to create that system for the uninsured, underinsured. Actually, it's the care we should create for everybody. We need to move from a system that's essentially no system, a series of silos, to a system that is based on metrics. We want to break down the silos that exist between the different segments of care, and we want to create one system for the safety net population that is based on data. We want to be able to look at how we take care of these folks and use that information to improve care downstream. So there's a lot of health information technology that needs to be built, but we are confident that we can meet that. Let me get to this last slide before I get something thrown at me. So what does progress look like? Where are we actually in this? Let me real quick go through this. In November 2012, we passed Prop 1. In June of 2013, the CCC was formed. Seton and Central Health signed the papers that basically created the collaborative and moved this work forward. And many of the people who did that are standing in this room, so thank you very much. In October, we ended the planning phase for the 14 projects that you see up there on that other board. And in November, we've launched the integrated delivery system. We have begun the work of implementing pieces of the integrated delivery system into the environment where we can begin to change care. What are we doing for the next year? Implementing all those projects. We have deadlines. We have to make sure that we're successful for what we need to do in this next demonstration year to draw down our federal funds to continue this progress. In 2016, we expect the Dell Medical School to open to its first class of 50 students. In 2017, Seton is going to open their state-of-the-art teaching hospital right down the street. And beyond that, as we finish implementing the pieces of the integrated delivery system, we will have created in Travis County what I believe will be, as I don't even want to say state-of-the-art, a cutting-edge integrated delivery system that will be a national model for the way you can provide care to humans. Now, in this case, it'll be humans that are uninsured and underinsured. It's my belief that it will serve as a model for all care. The benchmarks we intend to hit are benchmarks against the best care provided anywhere in the United States. I do not intend to provide care that is not of the highest quality. The goal here is simple. It's called the triple aim. How do we provide the highest quality care? How do we provide the highest patient satisfaction and patient experience? And how do we do that efficiently and lower the cost of care? We need to be able to do this inside of the real financial constraints that exist around healthcare. Because guess what? We have other things to pay for. That concludes my comments. I appreciate your attention.
Okay, so that concludes our presentations. I do invite you to come up and look at the boards here and come talk to Dr. Mark because he has so much knowledge in here. He wishes he could talk forever and we wish we could listen to him forever, but that's not possible. So please come and talk to him, come and talk to any of us, and thank you so very much for being here with us tonight.